document at the moment. I will hand over to Richard, who will explain and take us through.
You just took the words out of my mouth, Richard, so thank you for that. Good morning, everyone. What I'll just talk through is a sort of shorter slide deck that came out in your papers, just to sort of set the scene around this. As Richard says, that's very much a starter for 10 to start the conversation, really. But we're trying to link in with some work David's doing locally and things, and trying not to confuse people at a local level. So I'll talk that through in the conversation. But please, yeah, very much treat where we are today as a start of the conversation, not something for approval or anything like that. So if we can just click on probably a couple of slides, if you can go on to the next one. Just to set the scene for this, development of an integrated care strategy is a statutory requirement on us as a partnership. It was written into the Health and Care Act, so we have to produce something by the 31st of March 2023. The feedback has gone from, you should have a strategy 6 months ago to actually really looking where most systems are and saying these partnerships are still developing. And actually what we produce at the end of March is not going to be perfect. It's not going to be as good as it could be. So let's see it as a dynamic thing of improvement. But it is important to say, what are we trying to do together as partners? So it's there. Alongside it, particularly from an NHS perspective, there's two sort of supplementary bits. One is having an implementation plan. So what are we doing to actually deliver that strategy, particularly over the next 12 months? And then a slightly more detailed operating plan, which is really getting into the nuts and bolts. And for colleagues from the hospital sector and others, those are really quite important documents. But for us as a partnership, the strategy bit is really key. If you can just click us onto the next slide, please. The point of this slide, though, is to say, boy, we don't suffer from a shortage of strategy documents within our system. So we've got them at organisational level, we've got them often at service levels or area levels, such as urgent care or whatever. And we're developing them locally at a place level. So David and the team here are very much involved in a piece of work, developing a local strategy with partners on the ground. So the last thing we want to do is come and add confusion to that, let's be honest. It would be very easy to be duplicating requests out to the public, requests out to groups and things, and saying, how does this fit together? So we are doing our best to sort of write a holistic framework strategy, really, that sits around these other things and takes account of what's being said locally, but also says, actually, we are running a whole system, Bain, Swindon, Wiltshire, and there's some bits of that system that we need to pay attention to that probably feature more in our system strategy than perhaps they do in some of our place strategy. So I'll air some of that. But as I say, what we're trying to do is not add to the confusion and the complexity. And what we really don't want to do is duplicate processes. So David, I think I'm right in saying you're planning some public engagement and feedback. We don't want to send out two duplicate requests to the public. So we'll look at, how do we do this in a singular way? This all sounds very muddled, doesn't it? There is a logic to it, but we'll try and get it right. If we can just skip on to the next slide. This is just to give you a feel for where the three areas are that we're working with across Bain, Swindon and Wiltshire. So Baines have got a draft of their local strategy. They've also done some public engagement. They've had some public feedback and got some real messages in there. So things like access to services, probably not a surprise to people in this room, are featuring as things that the public are concerned about. So we're beginning to draw some of that knowledge in. Swindon are a little bit behind in that process. So they're still working, they're still developing things, haven't got their draft yet. But again, we're trying to stay close to the team, working with Steve Madden locally and sort of understand where they are and go at the pace that is right for them. And then David and the team here in Wiltshire have generated some draft material and are beginning to think about the sort of public survey bit. So we're trying to work with those different dynamics across the three. And as we said, we've thrown some stuff at a set of words, but Will is here absolutely to help us over the next few weeks to really bring this alive and make it more meaningful for colleagues. So if we can just click on to the next slide. David, is there anything you would want to say about that? Have I reflected fairly? Yeah.
Just to add from my comment, I am also chair of the Integrated Care Partnership, which is responsible for delivering the strategy. Can we just jump back 2 slides? Because I actually think there's a really good point there. The NHS is awash with what it describes as strategies. I could probably, in fact, when I retire, I probably would consider writing a book on the definition of strategy and its evolution. I'm not convinced that we've got a single strategy actually inside the strategies listed at the moment. I think we've got an awful lot of plans, but we don't have a direction. And what is needed is a direction. Certainly from Wiltshire Council perspective, we've been working really hard on defining that broad direction. And I think the critical thing we're going to need, and I'm kind of wearing two hats here, and I'm blurring them, I know, is that ability to provide direction without constraining the way in which areas that I will never understand the operations of an acute trust, for example, but without constraining the way they operate, but conforming that entire system, every bit of NHS health delivery, whether it be in the acutes, in other parts of the NHS, in councils, in the voluntary sector, giving that framework, that direction, say this is where we're going, and so everyone else can then work out how they work to deliver it. That could be interesting if we get the three places all having different approaches. I suspect that the approach Wiltshire is taking will be relatively much in line with the approach that I'm hearing from the different members of the collective integrated care system is the approach they want to take. Everyone seems to have roughly the same ideas, which is great. Putting them into implementation, particularly when people start assigning money around it, which is not our role, that's the integrated care board's role, that really is going to be interesting. But I hope that explains sort of some of the context there of where I think we need to be getting. Basically, we need to be doing prevention work. That's pretty much what everyone says when you talk to them. But how we tie that into the fact that we've got, I don't know how many 100 plans that are called strategies inside the various bodies. Yeah. Anyway, I will let you crack on now. Sorry.
Thank you for the clarity and also the sort of accompanying comments that sort of back up what we're saying. This is, we could easily get this horribly wrong. So these are some of the themes we are hearing coming through, and I don't think there's any surprises on this list on the left for colleagues. They are really key themes. So you've got things there around the tackling inequality, the prevention, that concept that people don't live in a health bubble. They live in communities and they live in families and they live in. So actually, if we're serious, the wider determinants of health and thinking about that. So you made the point, Richard, about partners around this table. This is where this strategy, we really need to be true to those things we've been saying about that. Very much a message around all age. This is really important that we think about particularly children and young people, perhaps an area where across our system in the past we haven't paid enough attention and getting that bit right. The point you've made about prevention. So lots of really common themes here, particularly that one around development of communities. This feels, particularly in the place strategies and the work we're doing with the three areas, the development of communities. So stopping us thinking about our buildings and our services and things and really talking about the communities in which people live feels like a theme that we're capturing through this. And then obviously that one about the environmental impact, there is a growing awareness that we have to be conscious to that in everything we do really, and how we bring together our net zero campaigns and things like that. So those are some of the themes of commonality. If you can just click onto the next slide. I've just listed on the left there that those are the sort of emerging top four themes that we've seen from Baines and Wiltshire so far. As I said, Swindon's a little bit behind, so I haven't got the same list for them. The words are different, but actually a lot of the sentiments are very, very similar, I think you'll see in those, and they largely reflect the previous list. So you can see the themes. So I think, again, Richard, I think my sense is there's a lot of convergence in these, and actually writing that direction and saying, prevention or whatever the narrative is, communities, whatever. I think there's a lot of common ground that we shouldn't be saying. Now, how we deliver that in central Swindon to rural Wiltshire might be different, but that's more for the implementation plan, as you say. It's not for the direction bit. If we can just click onto the next slide. This list feels a bit more NHS-y, and I kind of acknowledge that in a way, because as partners, we have the whole system. We genuinely have the whole system. So we have those organisations that sit in the communities, and we also have those organisations that run our most specialist services across the piece. And we think this strategy has to acknowledge both, because that is what the partnership is made up of. So there's some things in this list that we're exploring. We're not saying they're in or out at the moment, and some of them probably slip into that implementation space, Richard, that you referred to. But actually, let's make sure that our strategy does work for all the partners as best we can. So what is our vision around specialist services is as important in some regards as what our vision around communities are. Both matter. Where we put our emphasis on prevention and things like that in the future will be the shift. But again, our acute partners are talking very much about the way their role in prevention and things like that. So I think there's lots of common threads, but there are some areas where I don't think there'll be a lot of language in our local strategies that we might want to emphasise a bit more in our system one, if that makes sense. Is that okay with everyone? And then I wasn't going to go on too much more really with the rest of the slides. I was probably going to leave it there. The key thing we're trying to do with David and the team here is think about how do we want to go about gathering feedback in. So we very much welcome from this board, thoughts and ideas that colleagues around this board have, and thoughts on looking at the draft and what's there. But what we don't want to do is go out to your public in a way that cuts across anything you're doing locally, because that would be unhelpful. So we'll think about that. I think in all honesty, Richard, I think your point about direction, that direction will get informed beyond March as well as before March, if you like. And in a way, if we're going to be in a public debate, I think a lot of that will be post-March, because otherwise we will be rushing something through and the systems aren't quite ready. So shall I pause there and say, really happy to have any conversation about it. As I say, if you want to rip apart the current draft, that's absolutely fine. But it was about getting a placeholder down, really.
Great, thank you. And I think the point that the strategy will need, I mean, we're working to, in essence, a fake government timeline of March, and it's a little regrettable because it means that we are having to force things together before there is a chance to have that proper, broader conversation. There are so many different partners involved who will each have their own areas they're most worried about, and we need to bring everyone with us, the vast majority of people with us. There may be some dissent here and there, but we need to make sure the system as a whole is agreeing with what we're doing. Otherwise, we're just going to create something that won't work. So evolving that over time will be, I think, the only way. We're probably a year and a bit away from a proper functioning strategy for this, but we can at least set out the broad direction of travel, I think, in this one. Over to you. I mean, I could go on about this. I won't. I'll have other opportunities to do that. This is your chance to give your input, your feedback your thoughts.
Thanks so much for the presentation, Richard. I've got one overall point to make, and I think it's just a question as much as a request, but reading the document, it's still very medical heavy. And I think the challenge for all of us in this new environment is making sure that the social care element as part of the solution, as well as the wider public health elements, are brought to the front. Because we're going to go and consult with the public need to see that there is something that's different. It's just not an improved NHS, it's actually a different approach. And so I just highlight that as something that in subsequent drafts may just be some of the ordering, but we need to do that. I'd also endorse the chair's comment about strategies. I'm looking at page 65 of the document, the slide set, called Making It Happen. And there are lots of blobs and square boxes and lots of strategies. I'm pleased to see there's a BSW green plan, but that's the only one that's documented as a plan. And I think we need far fewer strategies, but more plans. And again, the public can understand a plan. This is what we've got, this is what we're going to do, and this is how you'll know whether we've done it. Strategies are important, but the thing about strategies is the process of developing the talking that's the important bit, not the document. The plans are the things that we can get our teeth into. And I think the other thing we need to all remember is this integrated care strategy, who is it being written for? How is it going to be a tool? I don't propose to try and answer that, but I think that's the thing we need to keep in mind, so we can keep it brief, succinct, and capable of being changed as we go forward.
And can I come in, Alan? So almost deliberately, we put something down so we could start that debate and get that challenge back in, and that's exactly the point, really. So I think we're seeing, as I said, in the local strategies, we're seeing a very localised, very un-NHS, if I can word it that way, bit. We want to some degree, blend the two, because both are important and get that reflected. But you're right, the planning bit is key. And I think what we probably end up with is a good plan that partners sign up to for the next 12 months. So if I use the example in Wiltshire, there's a lot of work around the integrated collaborative, neighbourhood collaboratives, things like that. I think there's pockets of things that we should be saying, do you know what, those are the things we're really going to drive over next year because they're really important, and have a series of those that we're really committed to. And I think that's where the narrative that we spoke about earlier becomes actually we all know what we're getting on with for the next 12 months. And, some of the stuff that's 3 or 4 years hence, some people may be doing some planning about buildings or whatever that looks like, but actually the real focus needs to be on those 3, 4 key things that we're saying, this is what's going to change it over the next year or so. Does that make sense?
And I think the point you make about the way in which different people the way in which language is used by different parts of an organisation or different organisations is really important. I had a very interesting discussion with Lucy Townsend, the corporate director for people, because my definition of strategy and hers were completely different. We were talking about the same thing, but we were using words in a context that meant we just didn't understand what each other was saying over it. The military definition of strategy, again, is different. Everyone wants to have a strategy because it sounds really important, but actually it's the plan, it's the delivery. That's the stuff that we often call the strategy, but is what we're actually doing and delivering on the ground. Somehow we're going to have to work through that wording and find a way that's going to bring people on board, because we don't want anyone to feel that what they're doing suddenly is being demoted, because it isn't. It's just, how does it all fit together? What's the direction that it fits under? So that's going to be, yeah. Please.
Thank you, Richard. I share your frustration about strategies, because for me, strategies that don't say what the choices are, what the payoffs are, and where the resources are going ain't strategies. But this is the NHS, so there you go. What I would say is that it would possibly be helpful for this board, while we're in transition into a place where we're getting to a rock on which we can build our partnership, is to understand or articulate what the problem is that we're trying to solve, which the integrated care opportunities allow us to solve, and how we would measure in 4 years' time whether we've succeeded in getting added value from the integrated care arrangements. And that is a discussion I think we haven't had, and might be helpful to help us shape our role as a board when there are so many other boards scrutinising what's going on in this space.
I'm not sure. I'll go to Sarah next, and then Laura.
Yeah, and I've written down something kind of similar, echoing what Alan and yourself said. So I think it's, what will it look like in 5 years' time? What's the difference it's going to look like, so it can be described to people? So what's the challenge we're trying to change? So what's the data telling us? And then what's the priorities that come out of that? And how can partners in the wider context solve some of that too? Because, you know, and I can see it talks very much about NHS partners, but where's the other partners? And, you know, because somebody's individual, and I think there's a slide that I remember seeing, an ICA thing about somebody's interaction with a health problem. The NHS is only part of solving that problem. There's lots of other people around them, family, carers, all kinds of people who will be part of that solution. So how does that work? So how do we all work to the same agenda? And those are the kind of things we need to think about. And then what's the priorities like in the first year to think the longer term, I think.
Thanks. Laura.
I would echo that. You made the exact point I was going to make. And I suppose what I don't know is, as a person, how am I going to notice the difference? What's going to be different now? I've got a sore arm. What's the difference between what I would do now versus what will happen in 5 years? And I just don't envisage that through this. I'm not saying it's a weakness of the document, but I struggle with all the different layers and organisations and so forth. Is what's it going to be like for an individual in the community that makes it different from five years ago? Richard.
And my observation going around and doing this piece of work is that we're struggling slightly in every area to get that specific and to apply that lens to it. So I think there's a real opportunity. I would encourage us both in the local plans, and you know, I was in Baines Health and Wellbeing Board this week, and the same point was being made about the local plan, where there were some goals, but there wasn't the specificity of what it would mean and what would be different. So I think there's a series of exercises we could do at place level, but also when we meet as an ICP, Richard, around, you know, how do we really want to describe that difference, and how do we get that, you know, through a public lens rather than through a service lens, if I can word it that way. And everywhere I'm going, I'm sort of seeing people slightly struggling with that, if I'm honest. And I think that challenge is the one we need to take back into all those places where we're doing this work and test it out and really say, how would we describe, how would you know we've achieved something in 5 years, or, you know, however you describe it.
I think part of the problem there is we also need to look at the government guidance as to what it wants ICSs to do. Normally, I would take government guidance with a giant pinch of salt and then try and translate it into something that worked for a rural area, not an urban one. But given the context that the ICP, the ICS, ICB work in, that guidance is more relevant. And they are very clear initially that it's about prevention. It's about making sure that less people are going to a GP surgery with a bad arm because they understand more about how to exercise without slipping over and breaking it when running, for example. I have no idea where that example comes from, but or that they understand that perhaps drinking wine quite as frequently as I do isn't as sensible, and you ease back a little bit, and that will make the demand on whichever service less. How you quantify it, good question. But yes, I mean, it's about taking some of the strain out to make the system work properly. They then go on to provide all sorts of other detail that I think becomes less and less helpful as you read through it, if I'm honest. But that's the overriding theme. Yeah.
Thank you, Chair, and sorry I was a bit late. And I think for us, one of the challenges is that the danger is that what we put in the document ourselves is what we're dealing with in the here and now. So reacting to some of the immediate difficulties that face our partner organisations at the moment. And the opportunity here is to take that step back and really think about the longer term, opportunities for our population, and particularly if we think about the agenda that we're going to talk about in a minute around health and wellbeing strategy. We look at kind of economic recovery and housing and travel and the things that really get in the way of us being able to, our communities being able to achieve their ambition and their goals in life, etc., which has a direct impact on how they use services, their health needs, etc. I think that's really where the opportunity comes, because that's something that all of us can get behind. It's not specific to any one organisation, but it has a direct impact on every organisation that comes together around that. So, and I think that's the opportunity, isn't it, Richard, that we're trying to really articulate. But it is difficult to try and do that in a way that everybody can recognise.
And putting a Wiltshire hat on for a second, that is absolutely the way that we as Wiltshire Council are approaching this. The only way we resolve this is by bringing every partner together that is relevant to an area to address that area. I don't want to be imposing that on Baines or Swindon if they have a different approach. So we, again, finding that, but when we come onto our strategy, that is what it says. We've now got the military sitting here. We need to have housing sitting here. We have discussed it. We haven't resolved it, but we've got a number of housing providers. But if we in this board are going to be doing our job, we've got to have all of those partners here to be able to bring that lens to bear. Because there's no point in sorting out someone's job prospects if their housing is substandard and it's dragging them down and it's causing a mental health issue that then impacts on the job issue. Sorry. I will get off the soapbox now, honestly.
As an example of something that's going to be different from April, on page, can't see the page, but it's another Making It Happen slide. And it says pharmacy, optometry, I can't say the word. Thank you, and dentistry. Yes. From April 23, BSW Integrated Care Board will become responsible for commissioning of pharmacy, etc., etc. My question is, that's new. In our new integrated care strategy, what's going to be different? Because we've now got the responsibility for managing that. And you could almost use that as a worked example. Because we've got this new authority, hopefully money, what's the impact in Wiltshire of actually doing that? Because we know that dentistry is a huge issue. Military families, for example, that'll come up later. So again, it's an example of something where we can use a change, something that's different. We can talk to the public. This is going to be different.
No, thanks. Good point.
Yeah, no, absolutely. And I think just because we move stuff around in terms of accountability doesn't change anything, does it? It's what we do with that freedom. And we know, don't we, we're starting from a base that isn't where we choose to start from. So, again, it's not going to be a magic wand, but it's a really good example about thinking about what we would do locally, because those pharmacists, those dentists, they're in those communities, aren't they? And how do we really engage at that level to say, how could this care system work? So again, I think, Fiona's got a lead responsibility around some of this work. So, it absolutely will be a sort of priority in there, but it's not going to be a quick fix in some of those areas. But the freedom to prioritise it and the freedom to think about it is what will come in those changes. So great point, Anna.
And we're thinking about 5 years, so.
Oh, I think we're thinking about 10 years, but yeah, sorry, Sarah, you want to come back in?
A couple of further points. One was about the data and picking up on Fiona's point around the future data. What's the impact? Is this strategy based on data as it is now, or does it take into account the impact of, say, cost of living, and then also long COVID and the impacts of, particularly our children and, the impact they had of COVID. Then the other part is there is mention in the strategy too about moving towards also think about social value, particularly in commissioning, and actually how does that work? And actually it's quite a lot of, I think probably some sharing of ideas that could happen around what does social value look like and what the impact might be. And then what future engagement is with organisations and partners, and how will that happen, so it's across the whole of the community, as it were. And then one small thing, and I raised this, we've talked about this before briefly in December, Richard, was about neighbourhood collaborative models. To getting down to the detail, it's quite difficult. You might bring together teams of medics together, but how does that work when you're quite scarce on resources within, say, it's our organisation or other county-wide organisations, about how you then replicate that and build relationships with those neighbourhood collaborative models. So I just flag that really as the voluntary sector.
And I think you make the point really well. All our organisations, whatever they are, operate at different scales, and they cover slightly different geographies. And Alison's, hospital covers a mix of different geographies. So we've got to flex, haven't we? We've got to understand that not everyone fits any unit, whatever unit we choose, and try and find that way of working. But I think that's part of the work you're doing with the collaborative thinking. Needs to take account of that. Where do partners really fit this model, and it's natural? Where do we need to, link and connect those things in differently? So, again, it's not an easy answer, but at least we're talking about those challenges and really beginning to explore them.
Great, thank you. And when it comes to dentists, we'd like them in the community. I think that's probably the point, rather. They're in some of our communities. Are there any other points anyone wants to make? We'll come on to this board's, the Wheelchair Health and Wellbeing Strategy, in a minute, which I think shapes more of our direct thinking. But I'm not picking up a great deal of inconsistency in the points we're making, and they're the same points I'm pretty much hearing everywhere else. So, yeah.
Thank you, Chair. It was just a point really about us as a starting point, understanding each other. I think that's going to be really important. You said right at the beginning of the meeting, we've got different faces, different agencies around the table. There's more that we're looking to invite, housing as an example. I think it's critically important at this early stage that we really understand what each agency does, what we can achieve, and actually how we can resolve issues for each other. Ultimately, the key word here is integrated, and I think that's what we really need to be. The other element is perhaps more of a tactical or even operational point. It's important that we've got those strategies and the plans, but it's having the commitment of agencies to actually embed those aspirations and those ambitions within our processes at the front end, because if we're not actually translating that into action, then we're not going to succeed. Thank you.
No, thank you. Absolutely, yeah. Great. In which case, if we're happy, the strategy a version will be pulled together by the ICP by March, because we're required to by government. And we will make sure that is shared, and we will make sure we do everything we can to consult and engage with the public over this. I think it's going to be interesting dealing with that in the time frame we've got and the sheer number of partners we've got. But yeah, great. In which case, if we then move on, I think we're noting that. Do we need to vote on noting something, honestly?
Yeah, I would do.
Right, in which case I'll move that we note it. A second, all those who are happy to note this. Great, thank you. No one's against. So we then come on to the draft joint local health and wellbeing strategy for consultation, item 7. And I don't have in my notes who's speaking to this.
Oh, I'm
You're speaking to it. Excellent, David, over to you.
Should be nice and simple. Yes, the word local is a new insertion from the statutory guidance, so it's an even longer title than what we had previously. Just to say a bit about the process, about how we put this together, we had the JSNA come out in autumn, so that's the statement of needs in Wiltshire. It's an important strategic assessment which is meant to both inform this strategy and the integrated care strategy. So we had that. We had the workshop in December at the Health and Wellbeing Board. I really appreciated your input. I hope you can see it reflected in this strategy, because I basically took the collated feedback and worked out how to frame it within the guiding themes. So hopefully you can see how what you said has worked its way through. And I've had a steering group supporting me, which has had Emma on it from the NHS and Public Health, children's social care, adult social care, public health watch, which are representatives too. So all really valuable input to it. You'll see the 4 guiding themes are the same as the previous strategy. We've been talking about what a strategy is. It's a statement of medium-term goals. We think it's important if you're going to deliver something over that time frame, you keep working with what you've got. They're also consistent with the themes in the council business plan. So there is a link through to delivery there, which is quite important. I mentioned the latest guidance that came out. That has been quite clear that the strategy shouldn't just list everything that everyone is doing. It's got to focus on those areas where joint action is required. So we're not going to list absolutely every employment or housing initiative the council's involved in, because we're not necessarily working on that with other partners around this table. But we will list where we are working on social value or where we can do things on employment together to help meet those important medium-term goals. I have got one quick slide. We talked about delivery, and apologies, people get blinded by diagrams sometimes. But I did just want to say that this strategy is meant to feed through into the integrated care strategy. It's meant to be an iterative process. We have due regard to each other's strategies. And so that it will evolve further over the next 6 weeks or so, just reflecting there will be developments in the integrated care strategy. Delivery, there's the 5-year joint forward plan, which is meant to reflect the integrated care strategy and this as well. The Health and Wellbeing Board has an opportunity to include a statement of compliance with the Health and Wellbeing strategy in that as well. And we get consulted on the ICB's annual report as well. There's 2 additional things that the strategy says in there around delivery, which are important. They are that it will inform the Integrated Care Alliance's work programme, and that's the next item which Emma's speaking to. Again, that's something that's going to evolve. But also that this board will receive progress reports on delivery against the goals in the strategy. So on an annual basis, we'll take something through the Integrated Care Alliance. We'll ask individual partners to say what they've done against each of the objectives in the strategy, so that this board can hold people to account for delivery. So it's not just going to be a strategy that sits on the shelf. Next steps, we have got a survey that's planned. That's Appendix 2. We've got a bunch of meetings coming up, which Richard and I will probably be both at or attending to, speaking to. So there's Health Select Committee next month as well. But we do want individual partners around this board to take the strategy and the survey through those boards as well. If you want me to come and speak, I'm very happy to do so. Please let me know if so. And then we bring the strategy back to the board for final approval in March. And that'll be alongside the latest version of the integrated care strategy. And we may even have a forward plan and operational plans for the NHS to consider at that point too. And that may not be it. We've got a 10-year, roughly speaking, timeline on the strategy. We can revisit it within that time frame if we feel the need to. But I think it's important we've got those medium-term goals clear and upfront. But yes, very, very happy to take questions on the content or just listen to discussion, Richard.
Great, thank you. I'm sure everyone's had a chance to go through it. Do we have any comments, questions? With anything like this, there are always things that could be seen as missing. Some of those, there's a degree to which we should be granular and a degree to which we've got to make sure it's a strategy. There were a number of areas. I'm probably have a bit of a reputation for wielding a red pen when I'm going, no, I'm sure I do. Officers aren't flinching too much. But when I get something like this, I certainly, when I went through, I've left the pen alone on this. But that doesn't mean there aren't areas where you could think, for example, from a Wiltshire perspective, should there be more direct reference to the military in there? I don't know. What elements? Yeah, it's a question. Are there things there that are important enough on that sort of big picture, but not referenced? Would be, I think, the key thing I'd be asking everyone today, as well as commenting on it itself. Laura, yeah.
Well, I agree with Richard that actually I found this a very good, easy read for a change, and it was in plain English and I could understand it, and I had a much better vision of what we are going to do. So I was very pleased with it, and I couldn't see any gaping areas. I mean, I always look to see if there's enough reference to young people, and I felt there was. I felt I was confident in that, and with the emphasis on the first 1,000 days of a child's life. So I was very pleased with this.
Yeah, I endorse Laura's comments. It's an easy read. It's good. My observation is on page 90 of the pack, the case for change. There's an opening statement that says, our current health and care system is under pressure and can be confusing for patients, families and carers. What I'd like to have added to that is staff. I spend a lot of time going around the county, and in the social care aspects and the care homes and the NHS itself, the staff are very confused by all this change that we're going through. And I think the strategies have got to acknowledge that in the case of change, they must be brought along and their views contained. So it's just a small thing, but the case for change, there's confusion amongst the staff as well. The people are actually going to deliver all this. So we just need to make sure they're not forgotten. And that obviously is included in the consultation process as well. Because at the end of the day, we're all going to be depending on them.
If you don't bring staff with you, you're not going to deliver anything. Yeah.
Just a minor point. But
Yeah, just a small one, yeah.
Thank you, Richard. And my people who briefed me also sent congratulations on the paper. It rarely happens, so enjoy that. The only thing I would add is that it would be helpful to know if you had an extra £1 million, where would you stick it? If you had to cut £1 million, where would you take it off? Because it gets you a sense of, this is very broad. So where would you get the most bang for your bucks?
I'm delighted to say that from a council perspective, we know exactly the savings we're going to make over the next 3 years. And we are releasing £13 million. So if you want to know where we would stick it, 10 million is looking to housing, because that's addressing issues that otherwise are going to cause all sorts of other pressures down the line. And then 2 million into what we're calling the community conversations, tackling deprivation. And the rest is primarily structural, but again, dealing with some of the declining elements of place, shall we say. But that's a council perspective and not a combined collective perspective. Sarah.
Yeah, like everybody else, I find it an easy read because you know what is it trying to work on to change. I guess for me, there's a couple of things. One is about engagement. March is not far away, so how the voluntary sector will be part of that engagement process. It's a clash of another meeting that happened today, and I don't know whether there's another Leadership Alliance meeting planned between now and March, but if it's going to be meaningful engagement, how that's going to work. And then, I've already shared this anyway already with the leadership, so people can start to have a think about this. Then it's thinking about those things, going back to data, what is we're trying to change, and the impacts there are. You know, if you look at just like, you know, the prevention agenda and early intervention, what's the impact that's happening now that's also going to impact people in the long term? Cost of living, access to services is huge. And people not being able to afford to get places, transport infrastructure, we've talked about housing. And just on the housing part of it, it talks about social housing, engaging with partners and other landlords. But from the data I've seen, the impact of cost of living, it's private sector landlords. That's where evictions are coming from at the moment. So private sector landlords can't afford their mortgages, and therefore people are being moved. So there's a lot of transient people that, you know, so people not feeling connected to communities because they may well have to move because of that impact. So the private sector is one of the big issues, particularly around cost of living.
Yeah.
Thank you, Chair. I thought it was great as well, by the way. It's a really refreshing document in terms of its brevity and, you know, getting to the kind of key points. So I would wallow in the positivity of feedback. I think reflecting on the diagram at the end that talked about the strategic links and the previous conversation we've just had, Richard, I think there's something to be gained from a kind of similar format, but also that emphasis on those wider determinants, the things that drive health and care needs, the things that drive inequalities. It's really clear within this document, and I definitely think there's something that can be taken from that in our thinking around the ICP strategy. Thank you, Chair.
Thanks. And I think the use of data is, yeah, it's absolutely key to driving it as well. Certainly from a council perspective, everything we're doing has got to be underpinned by data. Otherwise, I don't want to be doing it. But yeah.
I'm going to endorse the document again in terms of the brevity and easy read of it. But and I just wondered if there was an opportunity in engaging with communities around this to just feed in a little bit more of some of the changes that partners are expecting to see. So I'm really conscious that just from a Great Western Swindon perspective, we talk to our population and patients, but there's a real risk of doing that in an uncoordinated fashion, and that we are going to the same groups multiple times, asking slightly different versions of the same sort of question. And so I just asked for that opportunity to think about the detail of some of those questions and some of the examples that we might be giving.
And I think that feeds all the way down. If we are looking at how to address the needs of a community, we need to be asking them collectively. There's no point in us asking them separately. And more importantly, we then need to be listening to whatever they're saying. And we have a tendency as different parts of the public sector to occasionally not perhaps listen as much as we should. Sorry, any other comments, questions there? Private sector housing. It's always been a real pain engaging with that because it's not a sector. It's a lot of isolated individuals. We've tried and tried with virtually no success in the past. All we seem to be able to do is pick up the pieces. I don't know, I'm not sure what the position is. I don't know if I dare pick on Emma at the back there about whether we're making any headway. I know we've tried through housing a number of times to engage with that private sector landlords, and it just hasn't worked. I take it we haven't found the silver bullet. Yeah. Yeah, thanks.
But I just think it's using the data and asking people who are seeing some of those trends to say, okay, so what is that going to be coming down the line? So it's just what other people can provide some of that data that you may not see immediately coming through to the council. It's just seeing some of those things that we can see. You know, at Citizens of Ice, obviously, they can see the data around what's coming with debt, where that's happening and where it is particularly happening around private lets. So it's those kind of things that are quite useful to predict some of those things. And within the voluntary sector, there's quite a lot of rich data from qualitative computations as well as quantitative.
And the other element there that I think we need to be aware of, but it hasn't presented itself yet, is around mortgages. Because if you've taken out a mortgage recently and you are still comparatively young, in particular, there's a strain there. It's slightly less bad than it was looking 3-4 months ago, but it's still definitely there. Right, any further comments on the strategy? It sounds as if we're on the right track from what everyone's saying. Yeah? Great. In which case, I'm sure we need to note this as well. I'm going to work on that assumption. Oh, sorry, we've got a hand up.
No, I was just pointing.
Sorry, thanks. No, we're being asked to approve the draft strategy, right? For public consultation and consider feedback at our meeting in March. I'm very happy with that. All those in favour? Thank you. Then we come on to the next item, which is the Integrated Care Alliance Work Programme. I've got Emma Higgins down to present on this. Emma, over to you.
Thank you. And I'm really hopeful actually that I can pick up on some of the things that I've heard in the discussion in the last 40 minutes or so and give you some reassurance around some of the things that we're doing to pick up on those points that you've raised. If I can go to the next slide. So I won't go through the whole slide and the pack in detail, just to pull out some key points. So I think it's worth noting that our partnership committee arrangements are developing really well. We've had 2 full meetings and a seminar focused entirely around the outcome of the JSNA and our population health and wellbeing gaps, etc. in December. And we're taking that forward into our meeting in January next week, looking at both the ICS strategy, the joint local health and wellbeing strategy, and our other emerging priorities, etc. around and then developing our work programme going forward. So Richard and Fiona and others will also be at that meeting next week to develop that conversation further. And we are realigning our subgroup structure to ensure that we're able to deliver against those priorities and our work programme going forward, aligning with work happening in BSW and within Wiltshire. So we will continue to evolve that model and make sure that it's really effective. Next slide, please. Thank you. I won't dwell on this one, but it's just to give you our interim delivery areas until we can get to a point where we have evolved our new work programme around a population health and wellbeing focused approach, early intervention, prevention, etc. And I'll come on to that a little bit later. But it was just to give you a flavour of the sorts of things that are ongoing at the moment. This is not the totality of the work that is happening across Wiltshire, but it was just fair that we put some things down for everyone to be aware of and that can feed into the development of our new work programme. Thank you. If we go on to, here we go. So again, you've got some slides here that I'm not going to go through in detail. Hopefully, and I can take questions at the end if anybody has read through and would like to know a bit more. But I think it's worth sort of coming on to two areas in particular, the Neighbourhood Collaboratives programme and the Connecting with Our Communities. So I wonder if we can skip forward to that slide. I believe they're both, it's okay, there's the Alliance Neighbourhood Collaborative. So picking up on some of the themes of what I've heard you talk about, particularly in the strategy conversation and in the joint local health and wellbeing strategy discussion you've just had, I've heard people talk about making it work in at communities, bringing partners together, thinking differently, what's going to be the difference that our integrated system and our alliance can make. And for us, that's where we are really looking to see this in action at a very local level. So we have already established the Neighbourhood Collaboratives programme, and hopefully many of you will have been present when I've been talking about it before, but we've really made progress over the last few months. So we've established our Wiltshire-wide collaborative group, and our steering group, which is fantastic. So we have partners from the fire service, the police, the VCSE sector, we have our library colleagues there, etc. So lots of people working together in a way that they haven't done before. And we have a face-to-face group meeting next week, our second one. We're meeting face-to-face deliberately to pick up on how can we work together? What are we all working on together? Where is the alignment? How can we support each other? And how do we, as groups working across the whole of Wiltshire, offer support down into the developing individual neighbourhood collaboratives? We have established a Pathfinder group in Melksham and Bradford and Avon, and that is going to be a rapid established group to test and learn some things and share that into the wider programme. So building on the work that we've already started doing in the Trowbridge area in that system. Just as an example, picking up on something that I heard Alan refer to earlier in terms of housebound, we are working with people as professionals in that in the Trowbridge area. We have identified a group of people that our data for the first time is allowing us to indicate are likely to become housebound over the next couple of years if we don't do something different, if we don't support them in a different way, and picking up very much that in terms of the wider determinants of health, as an NHS service, we can do everything that we can possibly do to support those individuals. But if they live on in a top floor flat or in a really inaccessible area, there might be nothing that the NHS can do to support those individuals to continue to live and access out into the community. So how do we work together with colleagues that mean that we're able to support them in a different way and we see a different outcome in a couple of years' time? That leads me on to the next point, which is we know that the change is going to be longer term. And so this model that we're working towards in terms of the neighbourhood collaboratives is about genuine longer term sustainable change and the change that we work together and seeing our alliance living and breathing in our communities. And they will hopefully in a few years' time feel different. They will feel connected to those collaboratives. So we've got the Melksham, Bradford and Avon area coming up, and it looks like we are going to focus initially around falls, but that gives us a lot of opportunity to work with colleagues in all sorts of different ways around falls prevention, but also our response when someone has fallen across the entire sort of pathway. So working in all sorts of exciting ways, building in a way of looking at social isolation, low-level mental health distress, etc., and others into that programme as well. And then we will be expanding out our programme across the rest of Wiltshire over the next 12, 18 months, working with each of our neighbourhood areas on how we do that and building in support from all of our colleagues working across each system, both from Wiltshire and the local footprint area, to do that. And again, working with colleagues who are working in the community conversations programme at Wiltshire Council to make sure that we are in lockstep with everything that we're doing, and many other VCSE organisations, for example, who already have ongoing relationships with people in those communities. So building that system that you saw very briefly on one of the ICS slides as well. So very happy to keep bringing that programme back to share more with you, and we are developing our communication programme around that as well. So that's really positive. And then I wanted to pick up on the Connecting with Our Communities programme ever so quickly. So that is an enabling programme from our perspective, because it's about embedding how we are going to do different things and how we are going to work together to ensure that we are always seeking and taking account of the views of people that live and work in Wiltshire. And so that again has another meeting set, I think, in February, and that will be about prioritising the things that we want to do. So we've done some gap analysis work against what our national and local good practice looks like, and then this new meeting is about saying, okay, and what are the things that we want to prioritise for improvement? And we've got a bit of a test and learn exercise planned in terms of how can we, as a wider group of individual partners, provide support and feedback on the developing work, so that is embedded in the work as it happens, and we're not seeking to go back and do that at a later date or consult on a finished proposal. So this is about embedding that solution in, taking account of the people that live and work here to help do that. Again, very much aligning with the principles of the Community Conversations programme. And then I think the last point to make, I think if you go to the last but one slide on this one, so back up one. So I just wanted to pick up on this really quickly, because I think the things that we have worked through as an alliance, and I've put on this slide, really align to the things that you've been talking about. So takes that population health and wellbeing management approach to addressing the need, prioritises prevention and early intervention, values what our communities value, enables the use of our resources in a joint and genuinely integrated way, really supports and enables our staff and colleagues across the system to thrive, so that they can give their whole energy and attention and focus into supporting our communities. So we recognise all of those things, and all of that will be taken into the conversation next week, where we're starting to look at assimilating all of the different things that the strategies are saying, looking at our data very much. We've got some new population health data tools and working with public health colleagues and their analysts as well, and the JSNA outputs to say, synthesize all of those things. What is it that we are going to prioritise in terms of the real impact that we want to see? How are we going to measure that? And what are the priorities going to be for this year and looking forward into a longer term as well? So we will very happily bring the outputs of the partnership committee and those conversations back through this conversation as well, so that you are well cited on that. And many people in this group, I recognise, are also part of the partnership committee and will be cited on that conversation and part of that conversation going forward. I'll draw breath, but I'm really happy to take questions on anything that I've said or anything that is within the pages of this deck. Thank you.
That's great. Thank you very much. Do we have any questions?
Sorry to say this, but you didn't talk about flow, and I just want to bring to the notice of the board. So in my hospital this morning, there are 57 Wiltshire people who are there perfectly fit to come home. So they're deteriorating in hospital. Not good for them. My colleagues in the other acute hospitals have probably got very similar numbers in their hospitals too, who need to come home. I think everyone knows it's been a very difficult time. But the thing is, that number for the RUH has not changed for at least the last 2 years. And we are struggling with that. So it's very bad for those Wiltshire people, but it's also very bad for the Wiltshire people who can't get an ambulance, because the ambulance is stuck outside my hospital because we can't offload, because A&E is full, because 57 people from Wiltshire are sitting in 57 beds, deteriorating. We just not cracking this problem, and I know it's a universal problem in the UK at the moment. But it'd be nice to think that we knew what was really causing this problem and what we could do about it if only we had the resources. But I don't think we've even got an idea on it. I could not say that. I haven't said it for a couple of years. So, Richard, I'm sorry.
And I can see Lucy wants to come in. My question, sorry, just before Lucy, my question would be, do we know definitively for each of those patients what is stopping them leaving? Because in my experience, and my experience is more with Salisbury Hospital, you hear a number of different things from people involved in the system, people working in the system about a lot of factors that might be causing it. Do we definitively know in each case?
Yeah, so there are pathways of care, and we know where the pathways of care. Actually, sometimes it's easier to discharge someone who's more ill than someone who needs slightly less care. So we do know for every patient, and we do assimilate that, and we try and work obviously with our colleagues in all those services, but we're just not cracking it.
Right, sorry, Lucy.
Yeah, so I mean, I chair the Integrated Care Alliance, so I'll just kind of come in on that. I mean, what we're particularly trying to do in the Integrated Care Alliance is really look forward and be strategic about what we need to do for the population of Wiltshire. We know there is an immediate, crisis. We're well cited on that. Emma can come in a minute on some of the specifics. But there obviously are lots of various forums across the ICB where issues of urgent and emergency care and all of the challenges that hospitals are facing are being addressed. And there are numerous sort of forums where, on a daily basis that is being tackled. So I guess I just want to reassure you that happy for the board to get some more information on that if that's helpful. We've actually got a half-day workshop booked in Health Select in Wiltshire, where that whole system issue is being reviewed by Health Select in terms of applying some scrutiny to that. But as I said, in terms of this forum, we are really trying to think, okay, so we have these issues now, but what are we doing to address the needs of the population going forward? Because if we in this meeting took in hospital discharge to it, that's all we would end up discussing, and that isn't going to address the wider needs of the population.
Yeah, thank you. So I think just to add to that, we know our data. I think there is always some mismatch in terms of those figures, and probably, not helpful to get into the detail around that. We do know what pathway people are on, but we also recognise that often it can be a really complex situation why somebody is or isn't ready to leave. And I suppose just to give the assurance to yourself and the board and other colleagues here who may be from our other acute trusts, we are working as hard as we possibly can. We know there are broader strategic challenges around the availability of social care, which are leading to this issue, and the work that we're doing, again, in partnership around particularly the BCF and some of the funding that we've received over the last few weeks from government is very much trying to right-size our capacity and also get a much stronger understanding of what the overarching demand is, and actually is our capacity the right sort and the right size. Unfortunately, it's not going to be a quick fix, and I've had many of these conversations over the years and are as keen and as committed as everyone else really to resolve this into the long term. So I think we're going to probably have to manage for the next few weeks and months, and then really put some dedicated effort into going into the summer and having some longer term, more strategic solutions, which I think this will contribute to.
Laura.
I'm just talking about it from personal experience. I can't remember who said they were doing work. We're talking about a strategy on falls. And so my mother was staying here in Wiltshire. She fell out of bed. She's got mild dementia. An ambulance came and picked her up because we couldn't. But because she'd been on the floor for such a long time, they said she needed to go to hospital. And I begged them not to take her, and they didn't. And I just said, tell me what signs to look out for, and if it's bad, I'll take her in myself. Because I know she would have spent 9 hours on a trolley and been very confused, and it would have been the wrong place for her. And I was just wondering what we're doing about, of those 57, how many of them could have not come? Is there another way of just avoiding that so that you're not putting them in that position? Because I've got two friends whose parents were both, two mothers, were in for 7 weeks in Salisbury, and they just went downhill so fast in that period. And these were two women who were living independently. So I'm curious about what the strategy is to prevent people and giving the public that confidence to say that hospital is not the answer. Sometimes it's actually the problem.
I'm happy to come in on some of that, and then others may wish to join if that's okay. So there's a quite extensive and quite innovative piece of work that's being led from the BSW perspective at the moment, called Care Coordination. And that is very much working in a partnership approach, whether that's SWAST, our acute colleagues, community health providers, social care, and they are looking at those calls to the ambulance service and exactly doing what you've described. So identifying who actually does need to be taken to hospital and who could be supported in a different way, whether that is our kind of urgent 2-hour crisis response, our virtual wards. There's a whole range of options available to us. And other members of this committee around the table will have additional information, but I think it is certainly starting to demonstrate an impact in terms of those conveyances and avoiding people going to ED when there are actually other solutions for them. So we will be evaluating that going forward, and it may be something that this board is interested in seeing more of in the future.
Thank you. Yeah, please.
So we started the coordination centre at the Great Western in Swindon and have seen a reduction in ambulance conveyances as a result. And it does do exactly what you described. So instead of you saying, please keep my mother at home, there would be a care coordinator who would say, we will send a community nurse round, we will do a follow-up visit. And so exactly those sort of interventions to reduce conveyances in the first place. I suppose, just to build on Alison's point, in terms of this document, it's about all of these things will help with that, because it is about building that community resilience, isn't it? And it is about how we frame this in the context of the problems that we're seeing at the moment, I think. So all of these interventions will support in the longer term, and then it's about how tactically in the shorter term we can contribute.
In fact, just very quickly to say, my worry is that this has been the case for 2 years, probably more. So this is not a short-term problem that needs a short-term fix. This has been a long-term problem. So Claire, you're absolutely right. This is all going in the right direction. But hey, 2 years and we still haven't cracked it?
Emma.
Thank you. I just wanted to pick up on a previous point and just to add to what Emma was saying around our discharge communication project work, which I didn't point to, and of course that's right below urgent care and flow in the slide deck one here. And again, the slide deck would be 1 million slides long if we could put on that everything that we're doing in this arena. But also wanted to pick up on the discharge communications project, because again, it's another piece of Wiltshire driven, but will go across BSW innovation, national innovation around how we are talking to our residents and populations and patients and individuals and carers about our discharge services, how they can keep themselves well out of hospital, what they can do in hospital, talking about hospital as not being the best place for them to be once they are medically recovered, and talking about what happens after they are fit to leave. And helping them to understand that and to smooth the pathway for them, to help them feel more in control and engaged with the decisions that are being made. And that is in response to a big piece of work that we've done to engage with people who have been through that pathway, who have gone into care homes or have gone home with care and going into their home to support them. And with families and carers and all sorts of people and staff. And so that's in response to those requests to help navigate, picking up on Alan's point, what is a complex system and can be, when you're at your lowest point, overwhelming and confusing. So absolutely, we are working really hard to do that, and those resources will be in place for sort of September period of time. But we are being looked at nationally in terms of how to do this and the impact of this work as well. So that's really positive. So lots and lots of work going on. You know, for example, I think Emma's being really modest in not sharing that we have, as Wiltshire, dramatically increased the capacity of our discharge services over the last few weeks, and yet we're not seeing those numbers in hospital who are medically fit for discharge coming down. So there is a lot of work that we are doing as Wiltshire and has been recognised across the region in terms of particularly the Wiltshire effort and the Wiltshire service. But clearly there is a lot more still to do to really understand that problem, and there is a lot ongoing. So I just wanted to share that with you. Thank you.
Thanks. Sarah.
Yeah, I mean, I'm only touched on the edge of this as a voluntary sector provider and looking at where some of this all joins together. And I think a lot of this does all join together in the whole strategy of what's happening. So it's the prevention piece and what happens around trying to stop people being conveyed to hospital. And I think that the trying to raise the agenda and move forward on around falls particularly, because that is, the data shows that that's where it comes from. Lots of people being conveyed because of falls, and Laura gave a very good example of that, and actually people ending up in hospital which may not need to. So the more that can be done around falls prevention and progressing that agenda would be really helpful. The other thing I think that happens, just it's slightly anecdotal, but also was listening to a podcast from a GP about what happens about 111. And actually, because of 111, more people get conveyed because they've run 111 rather than ringing their GP and going through GPs. And so access to GPs has an impact on why people then end up ringing 111 and end up going to hospital. And I could, as an anecdotal example, I can give over Christmas, but it's, I think some of that happens. And so then, how can we educate people more, and what do we do about using technology like I Stumble, but about doing assessments of falls and trying to progress some of those things. And the last bit I think is just from my anecdotal evidence of working with discharge a bit on the edges, it's about how well people provide information that help the discharge process. So each of the hospitals, everybody's so busy, I appreciate that, but sometimes the discharge process gets held up because the data coming from the hospital or from the ward isn't what is needed in the community, and so that gets delayed, and so the information isn't available. And if you could say, for example, yes, they've got a key safe, but if nobody puts the key safe number down, then you still have to go back and find that out and go back to the ward, and it just slows down the whole process. And then alongside that, sometimes the equipment's not available, so if some of those things, so it's just about all those things coming together actually slows down the process for those people who perhaps medically fit aren't needing to go into a care home. I think the example, that it's easier sometimes when people are needing more care, but those people who are perhaps needing more care back in their own home, there are some things that needs a bit of focus about what is that data that's coming from the hospital and information that helps ease the community to be able to do that. And that's, I think, sometimes missing if the input was put in at the hospital end, it might speed up the process a bit of what happens in the community. So it's an all-round thing, but it just needs a bit of work on it, I think.
Thank you. Fiona.
Thank you, Chair. So not to prolong the conversation too much longer, but I think in terms of some of the operational challenges that colleagues have referred to, I'm confident that we've got the systems and processes in place, that the people on the ground are taking the right actions to try and address that. What I would reflect is that I think from an NHS point of view and care, we're in a chronic state of escalation. We've got to a point where we're in an escalated state, and we've been there for a long time over the last couple of years, and that in itself is causing us problems. I think the priority for us over the next couple of months is to try and find a way of coming out of that escalation state. It's not sustainable from a population point of view, nor is it financially sustainable. And that's the conversation we're having as an ICA, is that how do we move ourselves away from being in escalation over a long period of time? It stretches resources, it's an inefficient way, and it causes all the challenges that we've described today. So I think that should be our focus. And then alongside that, the work that we've committed to under the health and wellbeing strategy around prevention, early intervention, and trying to get in front of demand, because that's where the long-term opportunities for our population sit. And also it's sustainable from a financial and performance perspective. So I think we need to commit to that whilst allowing our teams to get on with the operational actions that are taken at the moment to deal with the here and now pressures. Thanks.
Thank you. And I think this conversation has entirely demonstrated what the integrated care system is here for, what it could deliver if we can make it work together, because the problems here are really complex and a myriad of different partners and a myriad of different causes. Anecdotally, I think I've had 3 conversations this week where people have referred to leaving hospital, 2 from Salisbury, 1 Southampton, where they'd all had a delay with a prescription that had meant an extra day. And then one of them had had issues with care that had meant further delays. And you're just looking at so many different elements that go into this. The only way to improve it is, it's almost back to whatever the principle they were using with cycling, about incremental improvements, and add them together to actually take enough strain out of the system that people have got enough space to do their jobs properly and therefore aren't under strain. it's not going to be easy, as you've said. But if we don't focus on that longer term goal, we're just going to be in crisis forever. I think that was, very interesting. I think it highlights the challenges. It highlights some of the solutions. Yeah. Any further comments? Anything else to throw at Emma from the report? Great. In which case, again, we're asked to note the report. I'm happy to propose that. All those in favour, please. Great. Thank you. We then move on to agenda item 9, Better Care Plan. Helen, over to you.
Hi there, I'm Helen Mullinger, I'm the BCF Commissioning Manager, and my manager behind me, Nick Mel, will step in if there's any questions that I can't answer. So it's quite often we have this agenda item actually after some of the discussions that have just taken place, because as my summary says, we had 4.2 million of some additional government spending, which went into the pooled BCF budget, which was to be spent on hospital discharge schemes. They were very specific about what the money could be spent on. Lots of good ideas on what we could do to prevent people going in, but we couldn't spend money on those sorts of schemes, unfortunately. We only had a short period of time to devise some of these schemes, as is often the case, unfortunately, with some of these funding pots. But actually, we worked very closely with some ICB colleagues, and there was a lot of hard work went on in the background to come up with some schemes that met the criteria, and as best we could, would be able to support the system that's is really struggling and facing some significant challenges. So we have got in place a number of schemes, and bearing in mind the first 2 weeks of these schemes were over Christmas and New Year, I have to give credit where it's due, because actually the outputs already from some of this, from the monitoring, we've had 2 monitoring forms submitted already. The outputs from that are significant already. And we continue to monitor that and help some schemes as they adapt. We've had people recruited, we've had interviews taking place. We've got a number of beds filled. We've also had, just thinking back to me, we've got a number of Care Act assessments. Some of the backlogs have been cleared from that. There's a lot of progress going on within those schemes. The only thing I would add from a future sort of proofing point of view is we have had confirmation from the national team that we will have further winter discharge funding. 23-24, they've mentioned 600 million. 24-25, they've mentioned an amount of around £1 billion. I don't know what the criteria for the spend on that will be, but I do think that, as Emma mentioned, we do have more opportunity going forward to perhaps better plan some of these schemes that we know will have some funding for. As was the nature of the beast this time round, we had to give some heed to what schemes can we get up and running really quickly, because this money has a finite period of time in our bank accounts. Hopefully that will change going forward. There are a number of bits we've been spending money on this time round that might give us some opportunity to pilot a few ideas that we've got, but certainly I think with longer term BCF planning, I've very firmly got this in mind, and I know ICB colleagues and social care colleagues have got this in mind. So that's where we're coming from here we'll continue to monitor this on fortnightly, so we've got lots of data around what's working, what isn't. There are significant challenges around recruiting to post, but we have put also some funds into retaining existing staff, creating capacity for existing staff where we can. And hopefully going forward, we can take the lessons from this and better plan. Now we know we're getting it next winter, we can plan for that. Any questions that people
Thank you.
comment on?
Fiona.
Not a question, Helen. It's just in support of the conversation. But just to say, Chair, at the ICA meeting next week, the partnership meeting, we'll be kind of kicking off the conversation around how any additional funding that might be coming into Wiltshire for next year and the year after, how we best use that in the spirit of what we've just described earlier around trying to get ourselves into a more sustainable position, moving away from kind of escalation to kind of a business as usual model that enables our community to be cared for in the most appropriate place. So that's part of that conversation. We do recognise, however, we've got to balance the books for next year and the year after, and there have been some of this short-term, non-recurrent funding that we've had previously in itself creates real challenges for us, sort of stepping things in and out, getting workforce in, and retaining staff is really difficult. So it's welcome that this money is coming through. And I do think it offers us opportunity. My understanding is it's in our baseline from April, as opposed to being a kind of winter input, which is great. Again, we can start to really plan around the longer term, which I think will get us into the right place. Thank
Yeah,
you,
that's
Chair.
certainly what the mini budget or fiscal event or whatever we call it said, yes. Any further comments on this? I mean, I very much share your views about the short-term nature of some of this funding. I think government are understanding that. We have made the point, and every time I get hold of a relevant minister with the opportunity to explain the need for long-term consistency, that's a point I make.
Just add a point to that, Chair, as well as the kind of longer term, the maximum flexibility about how that money's used, because I think that's also what's been difficult with some of the short-term funding is also there's quite a lot of strings attached, which then, you know, prevents us being as creative as we need to be to deliver the solutions. So any influence on that as well would be helpful.
I have a horrid feeling we're asking far too much of Westminster at that point to actually trust us, but okay. Very good point, yes. Lucy.
Yeah, and I just wanted to add, because obviously in terms of how we receive the funding, there are different ways. Some of it will come directly to the local authority and some of it will go centrally into the Integrated Care Board. I guess I just wanted to reassure this board that we want to ensure that we get the fair share for Wiltshire residents. But that's quite a complex picture when funding goes to the ICB. But I just wanted to kind of make that point.
I'm just going to endorse everything that's just been said. I think we need to acknowledge that everybody in this room is suffering from a funding model which is really not fit for purpose, and short-term funding, which is so restricted. I picked up the hospital discharge fund guidance, which I'm sure some people are familiar with. It's incredibly poorly written and it's got lots of links in it. So how you cope in short term to try and spend money, I don't know. So I congratulate you all for doing that. But I think there is a fundamental issue. We're talking about strategy here. The thing about strategy is you've got to be able to fund it. If you don't know the funding you've got and you can't actually make some local decisions, because we might in Wiltshire do some different things to our colleagues in Swindon and our colleagues in Bath. But if we're getting directions from NHS England saying you can only do this with it, that's a challenge that we all face. And I think we need to feed back that message very strongly. The ICBs have only been set up. They're already being reviewed under the Hewitt review. It seems a bit early to do that to me. But the ICBs need to be able to work with the local authorities and form the partnerships. And too much interference from above is not really very helpful. So I congratulate you all on being so tolerant with NHS England.
I think the faces say it all, yes. Okay, thank you. No further comments there. Again, we're asked to note the allocation, spend and regular monitoring of the BCF Winter Discharge Fund. So all in favour, please. Thank you. We then come on to item 10, the military covenant or armed forces covenant. It looks as though between us, Will and I are theoretically supposed to be presenting on this. There isn't a great deal to prevent and explain. I mean, the armed forces covenant is something that, from Wiltshire Council perspective, we've been signed up to from the beginning and remain signed up to. You would expect that. We have somewhere between a quarter and a third of the army based in Wiltshire. So it is of particular importance to us. I don't know if anyone wants to run through detail on this. Putting you on the spot, Will. I mean, I'm assuming we're taking it as read, but are there any edited highlights you want to give us?
It's more to bring to the Health and Wellbeing Board's attention that as well as the covenant has been in place for a number of years, there is now a statutory duty that kind of brings to the attention of both the kind of local government and health partners. And Wiltshire Council has done an exercise where we have kind of gone through the guidance to look at where we can be doing more and what we're already doing. And the kind of principle kind of bringing it here was also to bring it to the attention of our health partners and asking what activity they're doing the same. Essentially, it is a work in progress, and we'll be bringing some more back at a later date.
Bernadette, did you want to comment at this point?
Hi, very timely. Thanks for inviting me today. I haven't attended before, so that's why I've not done a paper, because I kind of wanted to get the flavour before I brought anything to you.
this is absolutely my arena. I work for the NHS England funded, but slightly arm's length, NHS National Quality Improvement Programme for military healthcare. It's called the Veterans Covenant Healthcare Alliance, slightly misnamed because we don't just look after veterans, it's about the whole armed forces community. That's really important. You're absolutely right, the covenant's been strengthened. There is now a statutory duty, or a stronger statutory duty. And we've talked a lot about aims and objectives and strategies and all that sort of thing. Ours is quite simple. It's about making sure NHS provider organisations, whoever they may be, including our third sector partners who might be delivering services for the NHS, comply with the overarching principles of the covenant about anyone of military status shouldn't be disadvantaged in terms of access to healthcare due to their military status, and it's about improving access and outcomes for that population. Really important point. I don't need to tell you this, you know it already. Wiltshire's got a massive military population. ONS last year, 2021, published recently that across England, 1 in 20, 25 people have some sort of military status. So it's important to bear in mind that it might be the young person sitting in front of you who is more obviously military, but actually there's old people, there's families, there's, you know, spouses, it's the whole group. In Wiltshire, we are a little better sighted on the detail of the population. We're doing a lot of work with our NHS partners, and that's becoming much more clear. Data is absolutely crucial. If you don't know your population, you can't possibly do an effective needs assessment and service plan and all of those sorts of things. So in terms of NHS providers, it's a slightly difficult line to tread, because obviously we do want to and are obliged to comply with the principles of the Armed Forces Covenant. We're also obliged to comply with the Health and Social Care Act, and that all access to healthcare, regardless of status, is based on clinical need. So it's it's not an absolutely clear message to give to people. We very much operate on a partnership model, and I'll describe very briefly, but you might find I'm picking up on stuff that's gone on this morning that you might want to think about to use. So we, broadly speaking, operate on 5 or 6 pillars. There's my own organisation. It's only funded for England, but we do work in Scotland, Wales and Northern Ireland in a supportive role. There is another element to it, something called the Veterans Trauma Network, which is much more aligned to very complex cases. Then there is Operation Courage, which is about mental health. We work very closely with MOD, the GP accreditation scheme and the third sector. So how it works, South West is in fact the most compliant in terms of providers against the 8 standards, Veterans Covenant Healthcare Alliance. The standards very briefly are: do you understand the covenant? Do you apply it? Do you know your population? Do you train your staff? Do you link with appropriate referral pathways? That's broadly speaking what we want NHS organisations to do. What's emerging, we're just 2 years in, we've just got another 3 years funding. So we've all got that perennial, we don't have recurring funding position, but you know, we've got another 3 years, so that's not bad. I'll talk to you a little bit about our local providers, because actually they're doing very well. So across the South West, generally, we're massively ahead of the rest of the country in terms of meeting those standards that I described. We're about 90% of the providers have met those standards. Our local providers have done really well. When I say our local providers, I'm talking about Great Western, RUH, Salisbury, Swaft, AWP. Those are the principal ones, really. They're at different stages in terms of their development. Salisbury, you will know, has been heavily involved in military healthcare for quite a long time. They deal with quite a lot of the complex cases. There's a very skilled plastic surgeon there called Alex Crick. She's in fact done the most operations on military limbs, for want of a better description, than any other surgeon in the world. So they run the War Injuries Clinic really successfully. Swindon has come a long way in a very short space of time. And there's some really interesting data that's come out of Swindon, which we are building on and working on. So Swindon reached the standards for BCHA accreditation about 18 months ago. And in that time, we've got a lot more data through. So what we're trying to encourage and make happen is that all NHS providers understand the population that's coming through the door. So in Swindon, they put a flag on the patient record. They are able to identify to a man their patient population and their staff population, because this is about both groups. So just one snapshot, in a 10-month period, Swindon identified nearly 8,000 patients who came to the front door, who had some sort of military status. So they're either serving, reservist, veteran, family, and they're able to break that down. They know which service they came from. They know the actual numbers. They know which part of the system they hit. They know the referral pathway, those sorts of things. Really interesting piece of information came out of that. They were able to identify that 60% of that 8,000 self-referred to ED. Really interesting. So they're also able to demonstrate benefits in terms of improvement in delayed discharges, improvement in readmissions. So we know this model works. And the model is this. Does the provider have that framework that I described in place? And then the next bit is, do they have someone within the organisation who you might call an armed forces lead, you might call a champion, whatever you want to call them, who then kind of takes up that care of that person holistically within the organisation. So Swindon, for example, has got one full-time equivalent Defence Medical Welfare Service officer. So the hospital deals with the broken leg or whatever it is. The welfare officer then does all the other bits that quite often will, for example, as Alison's describing, delay a discharge, for example. So it's, does this person need a wheelchair? Does this person need home adaptations? Does this person need referral to drug and alcohol services? Does this person need help with their families' access to housing, or is it social isolation? Do they need some sort of support in that way? It works incredibly well. And this is where we link very closely with third sector. And just an example, in another area where that worked, we had a lady in Cornwall, ready to go home, was actually end of life care, very sad, desperate to go home. We were waiting for a package in the normal scheme of things, which would have taken 19 days. We rang the Royal British Legion and she was home in 24 hours. So I think my point is this, is know your population, crucial, but very much linking with partners from the outset and overtly, so that there is that much more joined up ability to improve patient experience and patient outcomes. At this stage, we've so far demonstrated that at work. So we are rolling that out more and more, and that's a continuous improvement plan. We work with trusts for at least 3 years on a rolling programme, and they are expected to make improvements all the time. So there are benefits to patients, there are benefits to organisations, and there are benefits to staff. So it's a very much a whistle-stop tour. But I suppose if I asked anything of this group, some councils are now implementing that whatever strategies or policies or processes they're putting in place, that there is a specific assessment of armed forces population needs as part of the equality and diversity impact assessment. That goes quite a long way to understanding what's happening. I'm going to shut up now.
Great, thank you. And I'll come to you in a second, Viola. Just from a Wiltshire perspective, we know that we've got, whatever the ONS said, 37,000 veterans. We have at least 20,000 serving personnel in the county. you add in spouses, you're looking at probably 14, 15% of our population, absolute minimum. If you then want spouses of veterans or dependents of veterans, it will become significantly larger. We also know they vary massively from someone like me who did a short service limited commission based in Tidworth to people who've seen massive trauma in Afghanistan and Iraq. We've also got the Veterans Outreach for the Southwest that is coordinated through us. It operates over the entire Southwest. There are issues over funding there, and one way or another, worst case, we'll be using our some of the money we're releasing from reserves to make sure that continues from at least a Wiltshire perspective. I want it to continue from a Southwest perspective, but that is not within my control. So it really is of critical importance to us because it's so much of the DNA of what Wiltshire is. Fiona, sorry.
No, thank you, Chair. And it's lovely to meet Bernadette, and I will catch before she leaves today because we haven't met. But just so Bernadette knows, is I'm the executive lead for the ICB around the military covenant. So, and it's something that we've got to look at. Obviously, we have a legal duty. We've got to provide assurance to NHS England on our ability to evidence that we are meeting that duty. So it'd be great to catch up because it sounds like Bernadette's got a wealth of information that will allow us to complete that assurance process effectively. And obviously, Bernadette, you'll have the networks too. So just to say, the other thing, Chair, was in the paper, what you'll see is reference to the single point of contact pilot that we will be running in BSW. So one of several ICBs around the country who are leading the way in terms of the single point of contact. So I'll connect in with you as well, Bernadette. We'll talk about that too, because I think that is part of our ability to meet our duty under the covenant. So thank you very much, Chair.
Thank you. Do we have any other questions or comments there? I would hope we have a pretty good understanding of what this means from our perspective. It's just making sure we're doing it. Please, yeah.
So from my side as the ops manager, so I'm ex-military, recently out, but obviously I live in the Tidworth area, so I'd say the support we get is outstanding for the military personnel. I've dealt with Salisbury recently, a gentleman called Paul Russell. So a piece of work they've added is actually going back out to all the practices, but we receive the same update through my office out to our practices as if we're a civilian practice. So anything Salisbury are doing, we are informed at exactly the same time. So we can then tell all our SMOs and CMPs and all our doctors. But on the other side, he comes to our meetings now as well. So we run it quarterly, and he came to that and gave a brief on the work he's doing to support the veterans as well. We're interested in, but mainly the serving members. But the point he said is that at practice level now, they're being asked to identify if they're a serving member or a veteran. So before they even come into secondary care, you're aware that they're coming so that that wraparound care can be provided. So that's, and my boss, who's still serving, but a doctor, he's actually reaching out to all the ICBs in our area and building those relationships and inviting them. So we're trying to do it from our side as well. So we understand. The only thing that we would say over the covenant piece, and I'm not asking for any different treatment, I'm civilian now, so I'd rather be seen before my colleague, is the fact that obviously for us on the social mobility piece, also the rules within the military, 1 year of being downgraded, you are discharged from the army. So if we can't get them through the system and seen and treated, they could end up as a civilian with the same injury, but also unemployed and unhoused. That's the piece of work we're working with Paul. So we're not trying to beat the clinical system. If it's the same people, civilian or military, with the same injury, we're just asking maybe consider, it's got to be the same clinical need. I'm not trying to buck the system, so that a few times now, but actually, if there can be any work done around, we've gone to our mental health is a big issue for us at the moment. Our own doctors are now saying, well, we need to treat at the lower level to try and mitigate and being stuck in a system that our waiting lists are over a year. So we've got people on a mental health waiting list in the military system that will not be seen for a year. There's no point. We might as well discharge them at the early stage and get them into the social system. And that's the only thing I would say. So that's okay.
Thank you. Yeah.
Just a point to mention military families. Health Watch Wiltshire, we did a report in 2020 around the military families' experience of health and social care. It was driven by the rebasing project for people come back from Germany. The military families suffer the same problems that every family in Wiltshire suffers, but more so because they move around. And one of the things we highlighted in this report was dental treatment for children. And that's still an ongoing problem. Dental treatment for children is a problem to stop, but military families, they'll probably find a dentist when they're up in Catterick, they come down to Wiltshire, they can't find a dentist. I've personally spoken to mums who've actually taken their children miles and miles out of county to get dental treatment. They can stay registered with the previous dentist. So it's in the report we did 2 years ago. The final thing I'd say is the problem we had with the report was the MOD. When it was commissioned, there was a major from the MOD who was sort of looking at it from their point of view. He moved on. Another major came in, wasn't really that interested. So we found we got no response from the MOD about what they were going to do as part of the ongoing commitment to the military and military families. But it's a bit of frustration, really. You write reports.
It's a very interesting learning from engaging with the military, and we're trying really hard to make sure that the role understands the relevant role in our organisation, because particularly from the military side, you've got a 2-year churn process. Yeah, I think it's a really valid point. Please.
I'd agree. So I was the welfare officer at 29 Regiment, which is South Cerney actually, and we closed the med centre there and made all our soldiers go across to Lynham for safety reasons. But actually, if you look at where soldiers are recruited from, and historically, and I'm not going to disparage myself, I did 34 years, and I started as a soldier, but if we look historically where we recruit our privates and lance corporals from, and then we let them bring their families with them, and obviously they come from the same social background, we then bring them and we move them to an area that isn't geared up to really treat that, and we don't give you enough time or warning that we're going to add that population to your footprint. So there is issues that the defence need to look at when they're doing their planning and moving, because they don't, and they go, oh, look, they can go here, but they don't take into account schooling, housing, and that's military housing. So we housed everyone from South Cerney at Lynham or the other side of the M4, I can't remember the place it's called, nowhere near. They're 40 minutes easily away from their husbands or wives that are working. They don't drive. The houses are substandard. We can't get them into dentists or doctors, schooling. So we understand the problems. It's how we try and mitigate it before we bring in. But that social mobility piece means that there's a certain society that we're moving around that isn't geared up for the locations they're moving into.
Thanks. And particularly in the isolated bases, I think that's a big issue. I think Tidworth has an easier time given the concentration there. Dentistry, I've no idea how we fix dentistry. I'm sorry. I'm not going to pretend I do. Right, we are, if no one else has any other comments, I'm not seeing any. Again, we are being asked to do a number of things. I won't read it all out. Basically, make sure that we're following the Armed Forces Covenant and the duties involved. Again, if I propose that, are we all happy? All agreed? Thank you. We've been running for what? An hour and 45. We have one item left. Do people need a break, or should we crack on? 2 items. Oh, we've got 2 items. We've got 2 items left. We're going to take a 5-minute break just to be safe. Sorry. I know you've got a video coming, Rachel. So yeah, let's just take a 5-minute break. Right, we will reconvene at 11:20. This has nothing to do with my need for coffee, honestly. Right, it looks as though everyone's back. So if we could sit down and crack on, please. Excellent. Rehearsal time's over. The curtain's coming up. Right, okay. Our next item then is on item 11, the Workforce Health Campaign.
Thank you, Chair. So I'm just going to give you a bit of an update, something a bit different about a public health workforce campaign that was set to this board. I'm going to do a bit of a double act over here with Ian. So I will give you just a brief overview of what the challenge was for those of you that weren't part of the board a year ago, what the sort of response has been, and then I'll hand over to Ian to do sort of the what next, if anything. So about a year ago, we came to the board. There was a request about how could we get you collectively as organisations of the board involved in a workforce wellbeing campaign. Behind that, we collectively employ around 45,000 people. They're not all going to live in Wiltshire, but there will be a huge proportion of us that are Wiltshire residents. And we know how important good health and wellbeing is in employment. We've heard today about the integrated care strategy, our guiding principles of the health and wellbeing strategy. It's really great to hear wider determinants of health. Employment is one of those wider determinants of health. And so it's really important that we've got a healthy workforce. So what better place to start than with all the organisations around this table? So it is a bit different to everything you've heard this morning. And what you were asked to do was to go away and really think about the mental health and wellbeing of your workforce as a starter for 10, because, you know, we've had COVID and, you know, health improvement interventions don't always work if you've not really addressed that mental health aspect. So that was agreed at the board in December 21, that each organisation would sign up to go and think about a mental health intervention to improve the mental health of their workforce, and then to come back and report here 12 months down the line, which is what I'm doing today. And I will just, there was another element around the Health and Wellbeing Board signing up to the Mental Health Concordat. That hasn't happened because it didn't, I don't think it quite worked as a structure, but since writing this paper, I have seen some correspondence around an aspiration that the ICS within the Southwest will sign up to the Mental Health Concordat. So I think that's probably the best route. So although it's in here, it's good to see that that's probably the route that we'll take, and then by default, we're all signed up to that. So I think that's why I won't sort of talk too much about the Mental Health Concordat bit. So there's 11 organisations, I'm afraid Alan and the voluntary weren't quite included because there's only 4 of you, but 11 main organisations around the table. We've heard from 9 of you, so in the appendix 1 of the paper, we'll give the details. The other 2 organisations, if you're not too late to give us your update. So a lot of people focused on mental health first aid training, an international recognised training course to train up some of their employees so that they can recognise those early signs of perhaps signs of mental ill health amongst their staff, give that sort of first aid training. A lot did suicide first aid training for their staff. They've enabled health and wellbeing conversations amongst staff. So just really about, we all know that it's about talking about mental health and to not be worried about talking about that. So, and in Wiltshire Council, we introduced something called mental health advocates. So I thought rather than just having lots of slides, we went and found one of our mental health advocates who kindly done a 2-minute video just to talk about what they've done and some of the feedback they've had. So this is Wiltshire Council. It'd be really nice if we carry on after Ian talks, if other organisations would carry on with this, that we get other organisations to do little video clips perhaps next time, and then we can collate it so it's not just the Wiltshire Council show, but due to time, it's just this. So I think Ben, hopefully, is going to go to play.
Hi, I'm Jason. I work here at Wiltshire Council as an Assistant Commissioner, and I'm also a volunteer mental health advocate. As a volunteer mental health advocate, I've undergone training to raise awareness of mental health. Part of this role is to have discussions with colleagues, spark that conversation, and try to remove the stigma of mental health. I have developed some activities to help promote mental health because it's quite hard to reach colleagues, especially in this new way of working, hybrid way of working. A lot of people are at home. You don't normally get those conversations that you would have day to day if people were in the office. So some of these activities I've done is I've developed a blog. So I'm in the Procurement and Commissioning Directorate. We send around a blog roughly every 2 months. In this blog is usually an update from each team manager, but also includes a detailed section on mental health and well-being. In this section, there is details on improving one's mental health, and there's also what I call the spotlight section. So I usually ask a colleague to volunteer some information about themselves and what they do to maintain their mental well-being. This is an opportunity to get to know our colleagues better. And when we have those conversations with them, we can say things like, oh, I've seen you've been walking in the park. Have you been doing that recently? And if that colleague says no, then you might then be able to encourage them to do it a bit more, especially if you notice that their behaviour is changing. It might signal that their mental health is decreasing. So some more activities that I have planned, I do every 2 months, we host a team activity session, usually lasts for about an hour. So the most recent session was a murder mystery. So I sent people into breakout rooms, sent them evidence files, and they had to try and figure out who did the murder. And then they went back to a main room, and I was like a police officer, and they had to sort of feed it back to me, and we sort of figured out who did it. The feedback has been well received over all the sessions that we have done. So there's one colleague in particular who mentioned that they're a single parent, and it's the most fun they've had in a very long time. And this has sort of sparked our director, Helen Jones, who repeats this back to anyone, anytime she's promoting activities, to highlight the big impact it's having on our team. Being a mental health advocate is very important to me. As a parent and carer, we're always so busy, always doing things, and quite often you can sideline looking after yourself. It's important to remember that if you do that, then your mental health is going to decrease. And being a mental health advocate has allowed me to recognise that not only in myself, but in my partner and my colleagues at Wiltshire Council.
So I'm now going to hand over to Ian, who's going to talk about maybe the next step. Thank you.
I'm going to indulge myself and have a bit of a ramble in this as to how much we're contemplating on navels or actually doing something effective with our workforce in that. And I've listened to the word strategies and systems and processes and so many times today. And yesterday, I was actually part of an independent advisory panel visiting a military unit, part of a training unit, and we were told all about the systems and the processes and the responsibilities and all the acronyms to how the care and the well-being of the soldiers was being done and how it did. Then we went and met the soldiers and we spent 2 hours talking to them. What was their concern? The showers didn't work and so on. And my kind of reflection on that was, amongst us, amongst all of these systems that we might put in place, what's our own system of verification that it's actually penetrating, actually working down at the cold face, so to speak? The other point of reflection in this was that we are, however much technology we might bring to bear, people-based organisations. Nothing happens without them being motivated and in a good place and able to do their job. We're also anchor, with the term anchor organisations within Wiltshire. The number, 45,000 between us here. And 28,000's worth have been reported back on and how well we got on within those 9. I'm pretty sure that those 2 that haven't yet reported back, that doesn't mean they haven't done anything, and we really would like to hear what you've done in that, please. And then I had a little think about, and being new to this piece of work and seeing the report for the first time, well, you picked on mental health, mental well-being, etc., which is absolutely probably the right place to have started, and looked at the interventions that were there. And I slightly cynically thought, hang on, this is all safety net stuff. and actually I'm not quite right in saying that, listening to this, you know, I was probably being a bit too cynical, but I pondered, what are you doing, what are we doing to, never mind catch the individual problems and help people back, but actually build the resilience in the first place in that, and build the effectiveness of our staff. And the military have all sorts of, you know, but that's what they do. They train. That is what the military do as their day job. We've got another day job, which is actually delivering those services. And so, but how do you find the time and the space to actually build those people? I'm not going to give you my answer because I don't necessarily have one. I'm just posing it as a question. And so what I'd like to open up here is, where do you want to go from here with this? Do you want to carry on? Because this isn't complete yet. A good deal of work has been done. We've reported back. I'm sure there's more to be done. So you just want to stay focused on that? Do you want to turn to the other three, one of the other three areas that were mentioned when you first thought about this, and that's reducing smoking, reducing obesity or overweightness, substance abuse? It was actually mentioned as drinking, but substance abuse in its broader form. Or do you want to turn to some other area, aspect of building the resilience and capacity of the individuals and the teams in your workforce? I would like to throw that open and say at the end of that is, I'm not expecting some great conclusion now. There's the secretariat of this effort, who will pick up whatever comes out of the discussion. But I would just like to throw that open for discussion, please.
Great, thank you. For those who weren't here when we came to this sort of piece of work, the Health and Wellbeing Board historically had been a place where people came to show and tell, and it wasn't taking away projects, things to look at how we actually can start making a difference. This was the first one where we wanted to say, let's go and actually say, okay, if we're looking at health and wellbeing, let's start with our staff. I think we've got, probably in my assessment, a pretty good impact, but not perfect, in that there are still a couple of gaps there. But that's fine. I'm sure there's an awful lot of work going on that isn't captured there as well. We have got the piece on, drifting slightly away from workforce health, but we've got the piece around the community conversations, which we had said we would be looking at a report back in about 6 months' time from now, as the second piece of work that we'd identified and pushed forward. In terms of focus, we've now got the integrated care system coming into place, which I think has already given us, I thought it was possibly the most encouraging conversation I've heard about how we tackle discharge, albeit from a lot of different directions actually coming together to look at that more holistically. I don't know what those other issues that we want to be hitting are, whether they're some of the ones we'd identified before, what the issues are that you think we ought to be hitting. This certainly isn't one where a politician ought to be dictating. This needs to be evidence-based and coming out of the professionals. At which point, go on, you're the Health and Wellbeing Board, over to you.
I'm very happy to speak from a Great Western perspective. I think we have really embedded the mental health wellbeing agenda for staff, and I would be keen that we move on to something around physical activity and or smoking cessation. Those being the things that are the biggest public health challenges locally. I did just notice the reference to anchor institution and the role of large organisations as anchors, and we have got an anchor charter and commitment, and looking at employment routes for our more employment and training routes for our more deprived populations, and very happy to share that if that's helpful. But I would vote for, if we're being asked, I'd vote for, we're doing well on mental health. Can we move on to another one?
And you are being asked. Sarah.
Thank you. Just going back to the mental health for a minute, just the feedback I got from voluntary sector colleagues was we'd like to be included in part of that. I think some organisations at my own organisation, we had mental health training, we had first aid, we've got mental health champions, etc. But actually, it's that next step on about what you do next. And if other organisations have got material and information they can share, I'm lucky enough that we've got somebody who supports us, who come from Great Western Hospital, who's on the fringes of our trustee board, who's been sharing a lot of information with and she works in OD. So that's been really helpful to be able to share that information and be able to learn from it, assessments that can be made, how to do it, how to introduce it into your conversations with one-to-ones, kind of helping with our health and wellbeing strategy. So I think that sharing information as anchor organisations is really helpful, and the more of that could happen, the better. So looking at that, I think moving forward, if we can also be awarded, there's a huge workforce within the voluntary sector as well as volunteers who could be promoting and actually having those conversations if we've got the material to be able to use that out to other organisations and working with people and with people in the community. So whether it's activity or smoking, smoking is always a really hard one to crack, I think, but yeah, it's but yeah, the more that can be done to share information would be really helpful.
Okay, thank you. I've got a hand up online.
Hi, it's Val here from HCI Care Group. So first of all, apologies. I do think I've submitted and I've just resubmitted it, hoping it will come through. But I wasn't part of the initial discussions around mental health, but I think, and I when I was completing the template, I think it's really difficult to separate out mental health, physical health, social determinants, etc. So I would certainly welcome a broader approach. One of the things that we are focusing on, because it's a very clear impact at the moment, is the impact of cost of living on health and wellbeing. So we're doing a particular focus on that within our organisation, but I'd certainly welcome moving forward to a wider thoughts about health generally.
Lucy.
Yeah, thanks. Val said some of what I was going to say, but I mean, I think in terms of this is specific mental health piece or mental well-being at work, I suppose for the board may want to think about, workers, people have described what they're doing, and then kind of partly picking up on Ian's point. So, the impact of that, do we want to revisit that at some point so that we can evidence the impact that the board's had in that space? And I was thinking more generally, again, whether we could stick with staff or go broader in terms of the social determinants. And we've talked about poverty here today, social mobility, cost of living, homelessness, quality of housing, that was mentioned earlier at the start. So I think there are things that the board could focus on in terms of people's wishes, really.
Thank you. I wouldn't want to lose the fact we've picked a topic. It was deliberately a relatively constrained topic as something to start to get everyone to go away and think about. And the very act of writing down what you're doing makes you think about what you're doing, which is pretty much the purpose. I think it would probably be useful to get something brief back on this again in a year to see that things are being embedded and understand that that has continued. I don't know how much of the points you've just covered we will be picking up with the feedback on the deprivation community conversation piece. I think elements of it, but only elements. It'll be quite targeted. So I'm really open to how we take that forward. It's what we feel that. What I would like us to try and do is focus on an area and say, what are we doing to address this? And then report back, because that act of reporting back, it really does crystallize that thinking and make sure that what we're doing is sensible and joined up. We've had a number of suggestions, yeah.
I was going to say, because we mentioned in the paper, we've got the stats on our smoking prevalence and obesity and drinking, for example. So it could be that we say every organisation will do one of those. So you can then pick, depending on your organisation, and do it that way. Or we say, no, we're all just going to report back on what we're doing about reducing smoking or obesity, if that's the one. And then just one.
I very much.
It doesn't mean that all the other things don't go on, because they will be, and it gives us something to focus.
But I really think we need to be looking at something as a health and wellbeing board at the same thing, because we're meant to be looking at working collectively across the area. We've had a few suggestions. What do we want to grab? Yeah.
I just want to share if there's any value in looking at, because we cross boundaries, at the relative priorities of the other place-based partnership so that we don't end up crossing. So smoking cessation and obesity, I know work for Swindon. There are public health priorities. So one of those would work. I don't know about Baines, but I can't imagine it's much different actually, to be honest. It's
I think the only difference is the drug of choice in Baines and Wiltshire is more wine, and in Swindon might be less legal. Based on police data, I'm not picking things out of the air. It's based on data. Yes. Yeah, I go running wherever I go. There are places in the UK that are far more significant in their use of weed than the bits of Wiltshire I've run around, certainly. Sheffield, 6 o'clock in the morning. How can you... Oh, still. Right, sorry, we are completely digressing. Do we have a preference? Ian, what would you...
I just wanted to pick up, I think, on what was being said down there about activity. And is that more than talk about the kind of obesity and you're trying to prevent or remove something? Activity, to me, means you're building something more. And is there something around that that's to do with challenges, to do with... and I sit here also as the cabinet member for leisure or activity and centres and so on. Is there a piece in that might be relevant and attract to? Does that follow from what you're saying? I wonder if there's some kind of challenge or level of measurement of activity of staff. I don't know. I keep looking at Terence and hoping he'll tell me something on this.
Terence, you've been picked on. Do you want to respond? And then,
because he's got all the staff.
Well, I suppose I do have quite a few staff, but we've heard from Wiltshire Council about what it is that we're doing to try and encourage our staff to keep active. One of the challenges, obviously, is the hybrid ways of working, and the fact that we will have people who will be working Monday to Friday and then catching up on emails or doing other things at weekends, and that's half the risk, I think, that we have with maintaining a healthy workforce in the new working arrangements. So we do, I don't know, we still do walking appointments and walking meetings and things like that. I don't know whether there's because if we leave something for a year, I, you know, with all the best will in the world, I don't know whether all of the members of the Health and Wellbeing Board will be going back to their directors of HR and asking what they're going to be implementing as new ways of working. You would probably need to have some kind of agreement that the 11 or 13 partner organisations would have a discussion. We were talking only earlier about the arrangements we were going to be putting in place with a neighbouring local authority about having some physical activity by way of an inter-county games. So I don't know whether that's what you're referring to, or whether that's something that we could do internally within the confines of Wiltshire. But physical activity, is as an important part of mental health as anything else.
I think we need to go beyond our own staff at this point, really, with whatever we're picking next. Personally, I think if we're looking at it, it needs to be about what we're doing for that wider population. But yeah. I think we're talking about anything here. So yeah.
Thank you for that reason. And because it addresses health inequalities and is the gift that keeps on giving, I could see that a 12-month focus on smoking cessation. So when I look around the Heidi Hills on our site and find the staff who are not meant to be smoking there at all, they're normally the most junior, least well-paid staff. So there's a cost of living issue. If they're not spending money on bags, they might spend it on something better. But that can roll out then into their families as well. And of course, we see the benefits is that they stop being so ill and dying so early. So I would just put my hand in for smoking cessation. I know we need to do more on our own staff, but it does reach beyond that.
Okay, we seem to have two suggestions here, smoking or something around activity. What are we going for, please? How do we want to resolve this? Oh, for goodness sake, I don't want to come to formal voting, ever. Oh, for goodness sake. We're all just
On- on-
abrogating responsibility at
On
this
that
point.
basis, then I would go for smoking, because smoking is a very obvious killer. Hmm? But
Well,
the
let's find
I
out.
don't know what, our, again, I don't know what our rates of smoking are amongst
Fine,
our
let's,
staff. 12%. In Wiltshire, what about our staff though?
no, this is, we've got to go beyond, this has got to be to everyone now. Otherwise, we're navel gazing to an extent rather than spreading out to the whole. Okay. Sorry, you need to use the.
Use your mic.
Oh, sorry. Yes, I thought it was more of our organisations, because it's still part of like the core 20 plus the smoking. So there will be work across the system going on for smoking prevalence. But I think this is just about what are we doing for our own stuff, because we have such a huge staff base.
Otherwise, you're asking us to
Yeah.
vote on what public health will be prioritising over the next 12 months.
Well, I think we're asking to understand what is being done collectively to address an issue across the whole of the system. I'm starting to sound like NHS now. It's not good. Really not good. Right, definitely time. Okay, we seem to have settled on work around smoking. David, I'm going to ask you to pull this together into some form of meaningful approach that we can then take in terms of understanding, to report back in, again, are we looking for 12 months' time? So to go away, understand what we're doing, understand directions of travel, and pull together progress. Ian.
Just to say, I don't think we mustn't forget the mental health aspect and keep that rolling.
I think we'll need to see a report again back on that, just to ensure things are being embedded again in a year's time would be good. And while we're talking about mental health, if anyone can do anything about the behaviour of councillors in Salisbury and Trowbridge, you'll improve mine significantly. Right, moving on. Thank you. We then come on, Lucy, you were bringing an urgent item.
Yeah.
Don't normally allow urgent items, you're very lucky.
I know. So thank you very much, Chair, for allowing this urgent item, and apologies that the report was circulated late. Thanks for the slides up there. So I'm coming to give the annual report update from the Safeguarding Vulnerable Peoples Partnership. Just for those who may not know, that the SVPP are our safeguarding partnership arrangements in Wiltshire. We have statutory membership with colleagues from the council, our partners in the NHS and the police. And we draw together the children's and the adult safeguarding arrangements into a single board. And we also have the CSP chair represented at this board also. I'm the current chair of the board, hence me giving this update. So the first slide is really responding to our priorities in 2019-20, and it was real main focus of that period has been on safeguarding under ones. It is our most vulnerable group, unsurprisingly, given the nature of their age, etc. But that is also locally and a national issue. So we have done quite a bit of work in this space, and they're bulleted there. I won't go through each of them individually, but the one to highlight is that we now have a system, so across BSW, Safeguarding Under One's steering group, which has been established to drive forward work in this area, and that is led by colleagues in the ICB, hence the footprint, but that is also really important because obviously our health partners have the most contact with children in this age group, given the universal services, etc. Okay, next slide. Other two priorities there in terms of domestic abuse. So we do have a specific steering group around domestic abuse, which does report into the CSP and SVPP. But we've completed a needs assessment there. There's been a DA military forums, a lot of conversation around military today. There is quite high prevalence of DA in that population. So there's now a forum to address that. We've got some multi-agency data to look at improving our oversight and scrutiny of this issue, and also established a perpetrator and offender group, which is really important, and developing a local strategy off the back of that. I mean, I will say from a sort of children's social care perspective, about 50% of our referrals are in relation to domestic abuse. So it is our highest level of area of need in Wiltshire. Criminal exploitation. So we've been restructuring some of the groups, but this is Pan, Swindon and Wiltshire, the activity. That's because we share the same police force, so that makes sense. We have got more to do in this area to ensure that we have the right partners at the right level in these forums, but it is an area that we've, again, been focused on for some time. And just to highlight that we have also done a lot of innovation in Wiltshire on this, and we were the only area in the country to pilot a fifth category of child protection, which is called risks outside the home. So that's basically acknowledging that children are often at risk of exploitation despite parents' best efforts, and that involves a lot of work with our schools and local communities, and we're progressing further with that, so that's quite exciting. Next slide. In terms of evidencing some impact and also where areas of development. So particularly we focused on communication with partners. We had received some feedback that particularly, well, in both spaces actually, where we used to have different structures around the board, some of our partners felt more engaged and that they had started to feel less engaged, which, you know, we can't allow that to happen. So we have developed a new website which brings all the information together on both children and adults and the CSP. If you haven't had a look at that, you know, please do. It's quite accessible. We've got an e-newsletter. There are a number of stakeholder events. And also we've developed webinars to improve access to learning across the partnership. And some of those are kind of recorded on the website so people can access them even if they can't attend in person at the time. Hence my kind of encouragement for you to access that. We have identified that we need to do more. We deliver the training, but we need to do more to be able to close that loop and evidence that what we're learning from sort of practice reviews is actually impacting on practice. And then also we have got closer working with our schools through the establishment of an education safeguarding committee. Schools aren't currently a statutory partner, but we absolutely acknowledge and trying to engage with over 300 schools is not an easy feat, and having one rep from a school or two reps from a school doesn't tick all the boxes. So we've got this forum which is leading to some more success. And I just wanted to point out at this point that we are eagerly awaiting in the next few days the government response to both the Children's Social Care Review and also the review that the National Safeguarding Panel undertook into the deaths of Star and Arthur. And that will lead, I am sure, to some changes in safeguarding arrangements in the children's space. But also it will potentially lead to making schools the fourth safeguarding partner. But there will be consultation coming out regarding those. So in terms of system assurance, so I've said that it's now chaired by one of the safeguarding partners, which on this occasion is me as local authority. We did have an independent chair for a number of years. So I was the first to take up that role, but we are rotating and I'm probably due to switch anytime soon because it was for a 12-month period. And I believe colleagues in the police will take up that next. We have a number of, external scrutiny happening through various inspections. We've had the police being inspected recently. Children's Social Care at the beginning of last year had an Ofsted visit. We have kind of peer reviews and a number of different activities happening, as well as, HCRG had their inspections. So as a partnership, we've got a much tighter, getting a much tighter grip on all of that inspection activity that happens across the whole of the partnership, so that we are sighted on it, and it can either give us assurance or it can enable us to focus on specific areas. So clearly there's inspection activities happening in hospitals all the time in certain areas. SFT had some maternity inspection at one point. So we didn't feel that we were sufficiently sighted. So that's good work in progress. We've also got the child death process, and there's annual reporting around that. Just wanted to highlight, if you will recall, that there was the website Everyone's Invited, where we had anonymous individuals posting concerns. And it was off the back of the murder of Sarah Everard. This was a national website, and the testimonials were posted about peer-on-peer sexual abuse and harassment within schools. We were really, really proactive in our partnership in response to that, and we did a lot of work. And for example, there was one school in Wiltshire that received over 20 testimonials, and specific work took place with that establishment, including a safeguarding review. So just really to highlight how we respond. And another example of the back of some of the national panel reports that I've just referred to, we felt that we did need to improve our line of sight back through into the kind of MASH structure. So again, this is just applying to children at this point, but we have a MASH strategic board, and I think it is something that we would want to consider in the adult space also. And then there, in terms of adult safeguarding, I mean, we have acknowledged that we do need to do more in the scrutiny and oversight. It isn't as developed as for children. But as I said, there's been some scrutiny specifically around the MASH data, looking at quality improvement work on hospital discharge that we've talked about already today. And there was also a piece of work in terms of assurance in relation to the support that was being provided to the inmates at Earlstoke Prison who had care and support needs. That came off the back of a prison inspection, but that, you know, that was a good learning process for us to go through. In terms of practice reviews relating to children, so you'll know that there are statutory processes that we need to go through where we have significant incidents, both in children and in the adult space. Here we've had 3 notifications in this period to the national panel. I won't go into the detail, but you've just got some headlines there in terms of the reasons, some of those referrals and what the concerns were in relation to those. And then the next slide is focused on the adult reviews. Top one I just wanted to note, so there were 3 young adults with disabilities and autism who sadly died in a mental hospital. It was actually in Norfolk. And that was put down to very poor care and abuse. So that there's been a lot of national learning and a lot of work has been done locally in terms of ensuring, assurance around adults that we may have placed in similar establishments. So that was a kind of requirement for our colleagues within the ICB to report back on that, because a lot of these placements are commissioned by health rather than the local authority. But I'd also add here, there's also been some work nationally and locally around children who have been with very complex needs, who've been placed in essentially residential schools where there have been residential children's homes. And again, you probably read it earlier in the week. There were some homes up in Doncaster where there was some really significant abuse happening. As a result of that, the national panel did a sort of first stage review, and then they wrote to all DCSs across the country and asked them to review all children who were placed in such establishments and to share any learning. So we have undertaken that piece of work in Wiltshire, which we actually presented to Children's Select a couple of weeks ago. And I am pleased to say that there weren't any, there was some learning, but there weren't any significant concerns. So that gave us some assurance around our processes. And then again, there's an example of a safeguarding adults review there with Adult L and what the learning was in relation to that. And then just the last slide for me then, in looking at the strategic priorities moving in to this year and beyond. So we are looking at the creation of a strategic plan for the first time so that we can improve transparency and clarity for all partners on the key areas of the focus of the partnership. You can see what our priorities are there. I've already referenced safeguarding under ones and domestic abuse. Just pick up on transitional safeguarding. And transitional safeguarding is essentially the movement between adulthood movement from childhood into adulthood. Just because somebody turns 18, it doesn't mean that they're at any less risk. Done quite a lot of research on that in Wiltshire, and actually the needs of young adults who become, very vulnerable to exploitation, etc. Mental health is a really common theme. So a lot of our work has been focused around mental health. We aren't developing a team to respond to transitional safeguarding. That's not our approach. We are embedding it across, the entire workforce. We are getting some, expert support and advice from academics. We had an event only last Friday, I think, really positive, really good partnership engagement on that agenda, and we will continue to prioritise that. Again, I've already talked about exploitation, and then their social, emotional and mental health is, we've heard about it already this morning in terms of our staff, in terms of the military. We have seen the rise and the demand on services, so that must be a priority. And then in terms of the sort of golden threads through all of that, the learning from the case reviews as they happen, absolutely need to focus on prevention where we can, and early help and support, and that goes across children and adults, that we want to make sure that we retain our learning culture, rather than, let's not blame for where things go wrong, but let's really use it as an opportunity to learn. But also let's move towards reviewing where things have gone really well and what can we learn from that as well. The importance of leadership and culture is critical. Tomorrow morning, we're meeting as 2 safeguarding partnerships again across the police force footprint, so Swindon and Wiltshire, and the accountable officers. Terence, Keir and Sue Harriman are the 3 accountable officers for safeguarding in Wiltshire. And so we meet with them quarterly to make sure that they're kept up to date and can kind of provide an opportunity to provide some scrutiny. And we also have acknowledged that we need to do more on the independent scrutiny space. Thank you very much.
Marvellous, thank you. Any questions or comments? It all seems extremely comprehensive. There's nothing I can think of to add or say insightfully. Anyone? Marvellous. Well, thank you very much then. We will then come on to the date of the next meeting, which is the 30th of March. And at that point, thank you all for coming, and enjoy the rest of the day.